Welcome to our webinar on patellofemoral pain. It occurred on 7th of August in 2020 at 5 p.m. Australian Eastern Time. The webinar was in two parts. The first is a keynote presentation by Dr. Mark Matthews on his clinical trial of foot orthoses versus hip exercises for patellofemoral pain. The second is a question and answer panel discussion with Mark and 4 leading international authorities on this condition. It ran over 2 hours. So for the recordings, I've split the webinar into 2 parts. The first part, the first webinar recording you will view, is Mark's presentation and some very excellent question and answers. The second part is the panel question and answers session with some very practical insights into how to manage pain, patellofemoral pain, from leading international experts on the condition. Before we commence, I would like to acknowledge the support of UQ, the NHMRC, the National Health and Medical Research Council of Australia, and Vasily and FOHX for providing support. This research that Mark did takes funding and a lot of support, and we're very grateful for this support. We're even more grateful that we're able to do the research independently of the support. UQ provides all the infrastructure and necessary support to undertake research to the highest standards and to train the next generation of physiotherapists, both researchers and specialist musculoskeletal and sports physiotherapists. Hence the information on this slide of our master's program. Applications are now due. An interesting point is Mark, our keynote today, is a graduate of this program. The NHMRC funded the project in the main, and it did so through its program scheme. Vasily and FOHX provided orthoses and footwear, and they also provided some funds to meet the full cost of the study. As I stated before, the research was conducted independently of any of this support. So without further ado, I'd like to make a very warm welcome to Dr. Mark Matthews, presenting his clinical trial on patellofemoral pain. I trust you'll enjoy the story behind the FOHX trial, the rationale and the findings, and in particular, the question and answer session that occurred afterwards. It was thoroughly enjoying and could have gone on for a lot longer. As I said, great pleasure to introduce Mark Matthews, our keynote for the evening or this presentation. Mark is a journeyman, or in other words, he's travelled the world. He graduated at the University of Otago in New Zealand a few years ago. He first came to us, known to us as a Master of Physiotherapy student in musculoskeletal physiotherapy here at the University of Queensland. And I welcome all master students. Our students that are undertaking the sports masters are looking in on this presentation as attendees today, and also all master students and students around the world that have taken time to look at this presentation. So he was very memorable. He's energetic, Mark is, as you'll see from his presentation. And maybe wasn't smart enough to stay away from the place, came back and did a PhD. And what we're seeing tonight is the end product of his PhD. Now, Mark's got extensive international clinical experience. He's worked across many different public and private health systems. He's represented his country as a physiotherapist at Commonwealth Olympic Games and World Championships, particularly in cycling. He's currently a professional with a professional ice hockey team and is a lecturer at the University of Ulster, where he is the director of the Master of Sports and Exercise Medicine there, and has got many research projects. He's moved on. His major one currently is concussions in rugby union. So I think without further ado, Mark's going to present his study on patellofemoral pain, and once I find my control items, Mark, I'll disappear, and with great pleasure, I'll allow you to tell us all about your studies, mate. Thank you very much.
Yes, thank you very much, Bill. Everyone can, I'm assuming everyone can see the screen. Everything's running well. It's all up there. Okay, lovely. Team, I am absolutely fizzing to be able to present these results to you. It's been a real labor of love for me and for this research team. It's been a lot of work invested by a lot of people. In fact, 7 years, but I'll give you a wee story behind that one as well. As Brad has so already chipped in, I'm a little bit notorious for telling a good and engaging story that can run a bit longer. So I'll try and keep this as focused as I can and not run off on a tangent. But look, I'm absolutely thrilled that you're here, that you can watch, you can listen, and let me tell you a story and walk you through, where we're at and what we did with this research. Bill, thank you so much for the introduction, and to the panel members, again, thank you very much for joining in. And of course, all of the attendees, good morning, good afternoon, and welcome. And a tip of the hat to a few of my good friends who have chipped in to come and watch me speak. And hard to believe that I think it was 9 years ago that we first met and thought PhD was a ridiculous idea. But here we are. Okay, lovely. I would just like to echo Bill's comments around the financial support that we've received from the Australian government, NHMRC. Really grateful to have that and to be given that sort of opportunity. And also the support that was given through Vasily through the products and the money that they helped to give us. As Bill said, they weren't engaged in any part of the research. They just provided us with the stuff. Okay, lovely. So, coffee in hand. I'm certainly going to need one as we go through, whether it's a tea, coffee, some other caffeinated drink. So please sit back and enjoy. I hope that this is curious, gives you a bit of inspiration, maybe gives you some ideas and think about the way we do things. One of the first things, I was a real curious little wee kid. I was into everything. I wanted to know why. I wanted to understand stuff. Really thought like, I really need to understand, I was awesome at Cluedo, who killed who with a candlestick. And that's come through into my clinical training and being a physio, trying to get to the bottom of understanding the why of things. Why do we do stuff? So through my experience, we had access to a lot of orthoses, exercises and things for lower limb pathologies, and patellofemoral pain was one of the most common ones that I was seeing at the time. So couldn't understand, well, why did one guy respond? Why did one guy not? What is actually the best management for these sort of things? So hopefully through this talk, the why starts to illuminate some light bulbs for you. I certainly had mine through this plan, through the story, through the project as well. So I'm hoping you'll have some wee light bulb moments, things that may resonate with you, things that you maybe didn't know before, maybe also challenge some of the biases that you may have picked up over time. I'd just like to again acknowledge and say hello to all of the master's students, previous and past and present. Do not worry about your OSCE. Bill's not as tough as he looks, right? But anyway, thanks. Good luck, guys, and hope it goes well. As Bill's mentioned, I'm at University of Ulster University. I'm a lecturer in Masters of Sports and Exercise Medicine. I work with the Belfast Giants as a professional ice hockey team, and also involved in a private practice, a replay sports clinic as well. It's really important to understand that this is an evolution of knowledge, and we're presenting this project to you, but it's built on the shoulders of giants. There's been a lot of great work that's been done prior to this, other randomized controlled trials that have led up to this point here. And our understandings is always evolving. We start to get a little bit more pieces of the puzzle. So I'm hoping today that I can show you a few more pieces of the puzzle, maybe start to see with some challenge some pieces that are there that you maybe have thought of or taken for granted just a little bit. So here we go. So patellofemoral pain is a characteristic presentation. The patient will usually report the presence of retropatellar or pain around the kneecap or underneath it. It's usually aggravated by activities that load up the patellofemoral joint, and typically it's squatting, going up and down stairs, other functional tasks that load the joint in the flexed joint and load up the patellofemoral joint. But it's also a diagnosis based on exclusion, of ruling out all the other pathologies that we might see and happen around the knee. You're kind of left with this clinical presentation. It's prevalent. There's various studies have given different prevalence rates, but 25% seems to be around about the most commonly reported figure. And it occurs across the lifespan, right from adolescent right through to senior citizens as well. It's also a really persistent condition, and different studies have shown within adolescents, 2 years later, more than 50% are still reporting persistent symptoms. And certainly other studies have shown 5 to 8 years after being enrolled in a clinical study, over 50% are still reporting some sort of persistent symptoms that they're experiencing. So it's a real recalcitrant one and quite a sticky one, and it's common. So it's a really good one to get out, understand the why of it. Its etiology is kind of unknown, but it's regarded as a multifactorial condition. And by that we mean it's got lots of pieces to the puzzle, a lot of contributors, and historically it's kind of been viewed with a biomechanical or a neuromuscular rationale, some sort of consideration for load or overload around the knee, some sort of movement coordination type issues, some muscle performance deficits, but also something around mobility impairments, whether maybe too much or too little movement in certain joints. But there's this growing body of research that's starting to come out that's also highlighting the psychological contributors towards the patellofemoral pain. And those that present with it, you nearly need to be thinking about these 3 major domains when you're treating somebody. Now, historically, it's kind of been viewed as a local joint around the knee, but the evidence is really growing to show that there's this top-down, these proximal drivers to patellofemoral pain, as well as distal mechanisms down at the foot towards the knee that seem to have an influence around the patellofemoral joint. Proximately, if we proximal around the hip joint and pelvic area, there's classic signs that we may see within literature, this contralateral pelvic hip drop, the sort of femoral internal rotation and adduction, which presents to us with like a dynamic valgus. And that's things that we'd commonly see within clinic. We get someone to do a single leg squat and we're looking or thinking about that sort of dynamic knee movement as they squat. More distally though, historically it's been shown around excessive motion at the foot. You may call it pronation or just excessive mobility occurring at multiple joints around the foot. That can have an influence on the tibia and it creates greater internal rotation, which then impacts upon the tibiofemoral joint, which then indirectly impacts upon the patellofemoral joint. So this, again, this sort of dynamic valgus presentation occurring at the knee. Typically what we would see and think about and consider historically is this sort of joint stress through the patellofemoral joint. In a normal situation, the patella is tracking lovely through the trochlear groove. Forces are distributed equally throughout the medial and lateral facets. Now, as a result of the dynamic knee valgus, what's actually happening is not necessarily the patella tracking laterally, it's actually the femur and the trochlear groove underneath rotating more medially. The way I describe that is like a train running on the tracks. It's not necessarily the train moving off the tracks, it's the tracks moving away from the train. Now the thought is that that results in far more joint stress more laterally and results more of compressive stress. Same amount of force, but just on a smaller area, therefore kind of creates greater joint stress. And this has been presented before around this pathomechanical model. And you'll see down the bottom, sort of driving this presentation is impaired hip and muscle performance, as well as around the trunk and the pelvis, sort of causing these sort of movement patterns further up. But also you'll see down the bottom is altered foot and ankle, particularly strength, structure, mobility, these sort of considerations. It's important to note here, though, that elevated joint stress doesn't correlate directly to pain. There's a lot of other factors that have to happen between joint stress and the presentation of pain. And I just want to make sure that you're aware that there's a lot more mechanisms to this further higher up the chain, things that we need to consider about a bit more as well. So here we come to the management of patellofemoral pain. How do we manage it? And it's at this point here, I'd just like to take a quick second. Like, if someone typically presents to me in clinic with patellofemoral pain, where do I normally start? Where do I go when I start treating someone with patellofemoral pain? What are some kind of the key things I will look at and why? Just have a quick think about that. Lovely. Okay. So patellofemoral pain, as we know, presents, this sort of peripatellar retropatellar type pain. There's international consensus guidelines around the treatment of it. And there's been this recent publication of the clinical practice guidelines that's been published in JOS by Willie et al. And there's been a lot of guidelines about how to sort of the optimal management of it. And there's been 6 key recommendations. Within those 6 key recommendations is a suggestion of focusing on exercise therapy, particularly up around the hip and pelvis, targeting that sort of post-hip musculature, sort of addressing that. And there's a real sort of recommendation that we should be addressing that sort of thing. Equally though, within the recommendations is the suggestion that some may benefit from foot orthoses, and it may have an impact, sort of short-term pain relief. So what we've got is evidence saying, look, well, there's theoretical rationale for top-down and exercise therapy to target that. Conversely, more at the foot, the suggestion of excess mobility and foot orthoses, which kind of you think, right, here's a device that's designed to sort of control or manage the mobility. If we look at the evidence around that, there's a certain growing body of evidence. You know, studies have shown that hip exercises gives a superior benefit to just pure knee-focused exercises. So there is the evidence showing that this treatment does work. Conversely, with the foot orthoses, there's evidence from studies and massive RCTs showing that this, foot orthoses do have an effect and can help reduce pain. The interesting thing that here in my head is like, well, hang on, we've got two different options. I've got a bottom up or a top down. So where do I kind of go with those stuff? So if someone presents to me with patellofemoral pain, the guidelines are saying, look, do top down, do bottom up. But well, where do I start? What do I sort of manage, or which one's best? If I don't do anything and just make a diagnosis of patellofemoral pain, what's my best tool to use? So that was one of our first questions that we came up with. I was like, well, which is actually better? If someone comes in, where do I start with somebody? Not trying to tailor it, just think, where do I start? So that was one of the first questions with this big trial that we ran. The second thing is, well, look, studies have shown that there's a small group of people who've responded brilliantly to that treatment, whilst others in the same group haven't responded as well. So there's this idea about this sort of subgroups that respond well to one specific treatment. So these best practice guidelines that was put out by Barton et al. In 2015, it's sort of a consensus statement, but of an evidence base, sort of merging thoughts, clinical practice, and the evidence, came up with 4 key overarching principles. Number 1 was that we should be individually tailoring treatment. Number 2, focus on getting an immediate pain relief to help get the patient engaged and get the buy-in. Number 3, patient empowerment, get them engaged into the treatment with a suggestion that we should be focusing on active over passive interventions. And the 4th one is around patient education and activity modification within the context of what that patient is doing or person is doing. Now if we jump to actually the first one, the individually tailoring, well, actually, how do we do that? If I'm going to tailor a treatment to somebody, what are the things I want to be looking for? And now what we would call treatment effect modifiers, okay? These are things that you guys have already been kind of looking at, but this is the term for them. It's a patient characteristic that's associated with a successful outcome to a specific treatment. So we then did a systematic review and looked at it, right? Well, look, what does the evidence actually suggest? What has been shown and reported before to be these sort of potential treatment effect modifiers that may help me sort of tailor my treatment a bit better? So the study, we looked at baseline characteristics that were associated with 1, a poor patient outcome, a prognostic factor, and 2, treatment effect modifiers. So, they modified the patient outcome from a specific treatment. If we look at the poor prognosis, there's 12 studies that we captured in this review with 16 characteristics that were associated with a poor prognosis. But by far the most consistent one was duration of symptoms. The longer that someone has had the symptoms, the more likely they are to have a poor prognosis. And this cutoff of around about more than 4 months of symptoms, this person's starting to head towards having a poor outcome. If we look at the second part, which was looking at the treatment effect modifiers, we found 12 studies that had sort of reported treatment effect modification. From that, there were 6 treatments that were looked at, and predominantly it was foot orthoses. Of the 12 studies, 6 of them focused on, treatment effect modifiers for foot orthoses. There was 2 studies that looked at a lumbo-pelvic manipulation, and the rest of them were single studies, standalone, looked at things like neural mobilization, stretching, and leg press, other sort of local exercises, things around the knee. But by far the most common one was with foot orthoses. It was the main treatment that had been looked at. Across those 6 treatments, 22 characteristics were associated with a successful outcome, were reported from these studies. 14 of them were associated with foot orthoses. There's always a but with research, and there was a big but with this research that came through. There was 2 really crucial methodological considerations from all those 12 studies that had been presented. There was this overfitting of data to the sample size. What that means is they'd collected a heap of measurements and applied it to a very small sample. The second thing was this absence of a comparator treatment, something of equal or comparable sort of effect or comparable sort of success rate, comparable evidence-based treatment. all of these studies were missing this. They weren't able to compare it to something. They just took a group with patellofemoral pain, gave them a treatment, looked at those that responded really well, and looked back at the baseline characteristics and sort of what separated them from those that didn't respond, and then reported it saying, look, this was associated with success. So what those two limitations mean is that there's a much higher risk of what they report with spurious findings, and were not truly reflected within a clinical population. However, one of them did show up as quite a potential treatment effect modifier, and it's this thing called midfoot width measurement. To talk you through what that is, you take the person, you get them to stand up on a platform, and you put the heel back into the cup, and you measure the total length of the foot from the heel to the toe. At the halfway point, or half the length, you then draw a line across the top of the foot and define that as midfoot. You then use a set of calipers and measure the width of the foot in a weight-bearing position. You then measure it again in a non-weight bearing position, exactly the same line perpendicular to the sole of the foot. And you'll end up with this difference, the difference in the width between weight bearing and non-weight bearing. And what two studies reported, and they showed, was this consistent measurement of around about 11 millimeters difference or more. Meaning that if you had more difference in this foot, if you had greater movement or greater mobility through the foot, you're more likely to have a successful outcome with foot orthoses intervention. So the deal is like, look, it seems to be something about midfoot width mobility seems to be associated with success foot orthosis. It had to be true tested, and it had to be tested against a comparable intervention. A la the FOHX trial, foot orthoses versus hip exercises for patellofemoral pain to see if foot mobility was associated with outcomes. For those that want to get a bit more into the methodology, this protocol has been published. This is it here. If you can't find it or access it, please feel free to send Bill or I an email and we'll forward it out through to you. From here on in, we're going to be now talking about the FOHX trial itself. So hopefully I've explained the rationale, the reasoning, and kind of why we looked at it. You know, also drove me to do it from a clinical point of view and a curiosity point of view, especially curiosity. So from here on in, we're now going to be presenting the study and what we did. So here we go, FOHX trial. It was conducted a multi-site. It was conducted in Australia, in Brisbane, and also in Aalborg in Denmark with the assistance of Michael. And Michael, thank you so much for being involved. Really appreciate all that you did during this trial, and especially for me. We used the definition and the sort of classification of patellofemoral based on a consensus statement. So we had the inclusion criteria that was adults aged between 18 and 40, and was with diagnosis of patellofemoral pain based on a non-traumatic origin of symptoms, greater than 6 weeks duration. It was provoked by activities that load the patellofemoral joint, you know, such as running, squatting, up and down stairs and jumping. And they had to report more than 3 out of 10 pain over the last 7 days. So there's this kind of consistent, persistent pain presentation. And as I mentioned, it was a diagnosis based on exclusion of other kind of concomitant knee pathologies or something else that may be going on. And we then wanted to look to see, well, look, what did the evidence show around, you know, what was a good hip exercise protocol? But also we wanted to make sure it was clinically feasible. Both, you know, we were very strong on this. It's like, look, if this study works, we want to show that you can do it in clinic, straight off the horse's out of the horse's mouth, you know, off the bat, you can use it straight away. So we found that the Fukuda protocol was very good. It was, you know, we managed to restrict it down to 30 minutes. And we also selected the foot orthoses protocol used by Collins et al., which was it was the largest randomized controlled trial done with patellofemoral pain, and foot orthoses was one of the key interventions used in that study. So the HIP protocol, what it consisted of was 4 weeks doing 12 supervised treatment sessions, so 3 times a week. We gave no home exercises with it, meaning the person came into the clinic and did their exercises with the physio supervising. And we did that to ensure that we got good adherence, but also we could make sure they did the exercises properly and we could record it. We want to make sure that, you know, we're trying to tick all the boxes here. There was 4 exercises this included, using elastic band for resistance, and exercises were done both on the left and the right leg. Each repetition had a 5-second time under tension. So every rep, 5 seconds, the muscle was under tension. It was 2 seconds concentric, a 1 second isometric hold, and then 2 seconds eccentric, with a 1 second rest in between. We also ensured that the exercises were working them hard, so we could adjust the resistance and use different grading of elastic band to make sure that it worked hard. And they were reporting somewhere between a 5 to 7 on the Borg RPE scale, so hard to really hard with the exercises. The 4 exercises. Number 1 was hip abduction and side lying. And you can see that the resistance tubing was placed just superior to the malleoli, and the physiotherapist was monitoring, making sure they're moving through good movement and also staying still at the pelvis. Second one was doing hip external rotation and 30 degrees of hip flexion. The rationale for 30 degrees was that at the point the heel strikes the ground, you're approximately in about 30 degrees of hip flexion relative to the trunk. So this was why we were looking to, right, let's try and strengthen and do some exercise with this muscle in this sort of position here. The third exercise was doing hip abduction and standing. And I just need to note here that yes, the hip moved, the leg moved laterally, but also slightly posterior as well. And the foot was slightly internally rotated in. Purpose was to really target that posterolateral hip musculature. The fourth one was doing hip extension and standing. The person started with approximately 45 degrees of hip flexion and then extended back into a more neutral position. Didn't go fully all the way back, but they wanted to make sure it was just pure hip on pelvis movement, that there was no lumbo-pelvic compensation as they're doing the hip extension. The foot orthoses protocol. Now these were prefabricated foot orthoses, off the shelf, off the box, straight out of the box. The physiotherapists had the ability to modify the hardness of it, the volume of it. So you can see there's a selection of different orthoses that they could use, full length, 3/4, and also an easy fit option. But it fitted on, it must be comfortable. And they were allowed to modify it using different wedges at different points and also heat guns to try and soften it. And the entire focus was that this foot orthoses must be comfortable. They were also supplied what you may call, or in the UK, as a flip-flop. In Australia, it's called a thong. But if I'm going to go with my New Zealand, it's called a jandal. Right? So they were provided with a contoured jandal as well. And there was also something that they could wear around outside as well. So if they couldn't wear a shoe, they could also wear this jandal as well. They also had some home exercises to be working on, and some gentle arch forming, oops, go that way, arch forming exercises, and also some calf stretching that they had to do daily. Now the group, once they were recruited, were stratified into subgroups. Those that presented with more than 11 millimeters or more of midfoot width mobility, we defined them as a high mobility group, and they were subgrouped into that. Those with less, they were called low. So when it came to the sample size calculation, we were trying to test for a really strong effect. We weren't looking for something small or maybe. We wanted to make sure, look, if this is going to be true, if this is a true treatment effect modification, that there was this big interaction effect. There was a big difference, that the foot mobility interacted really well with the foot orthoses and they had a really strong success relative to the others. So on the assumption based on previous literature, we were assuming about 20% of our population that we recruit are going to be high mobile. We ended up with a total number of 220 participants, and this allowed for about 15% lost to follow-up. Our primary outcome measure was a global rating of change. It was a self-reported measure, 7-point Likert scale, and our primary time point was at 12 weeks. That was our key point of interest. Those that reported that they were better or much better, we defined them as a successful outcome. Less than that, that was an unsuccessful outcome in our eyes. To kind of further support that primary outcome, we selected a big wide range of secondary outcome measures as well. Now, these first three I've put up are patient-reported ones. It's their thoughts, their evaluations. The Borg is a self-report, the GROC is a self-reported scale. We were using other ones to help support that finding as well. So we used a thing called a single assessment numerical evaluation, which is just dead simple. It's a scale of 0 to 100%. So we asked them, look, on a scale of 0 to 100%, how normal do you feel your knee is? Later on, after the treatments, we say, look, how much recovery do you feel that you've achieved during this process? The pass or the patient acceptable symptoms state was a simple yes/no question. Look, is your current situation, your current symptoms satisfactory, and are you happy to accept them as they are? Yes or no? But also their perception of treatment success. Did they feel that the treatment for them was a successful outcome? And did that match well with what we defined as a successful outcome? In support of that, we've used traditional questionnaires that are commonly used within patellofemoral pain, such as the anterior knee pain scale, or more commonly known as the Kujala scale. And the others they're listed there, but also just want to draw your attention to the knee injury and osteoarthritis outcome scale score, and it's made up of 5 separate subscales as well. So there's another one within that. We also collected some psychological studies, questionnaires that looked at sort of kinesiophobia, anxiety, depression, and pain catastrophizing measures. We also did look at performance tests. In particular, we looked at isometric hip strength of the abductors, the adductors, and the external rotators. We recorded the strength at baseline and at follow-ups. And we also did tests that normally aggravate the joint, the patellofemoral joint, and cause patellofemoral pain, step ups, step downs, and squats. The number that they could do pain-free before they started to experience their symptoms to see how much they changed. We also took other classic, foot measurements such as, navicular drop, foot posture index, great toe extension as well. So we collected some other sort of baseline measurements as well, sort of standard characteristic measurements. If we look at the flow of the study, we assessed over 2,000 people for eligibility, excluded obviously a lot, and we ended up including 218 people into the study. 2 were erroneously included and they were removed from the study. Now, all baseline assessment was done by a blind assessor. All of the measurements that we talked about, that person was blind to A, their stratification, and B, the treatment that they received. If we quickly look across the study, across all of this is kind of the split that we got. We had a much higher female representation in this population, and the average age was give or take around about 27 years. The rest of the stuff is presented there, but the key thing I want to draw your attention to is the duration of symptoms. I'd said to you earlier that more than 4 months was associated with a poor prognosis. On average, our population was reporting symptoms for 53, 54 months. You're looking 4 to 5 years on average, these people have been having patellofemoral pain. Doesn't bode well if I'm saying less than 4 months is a poor prognosis, but here we go. Right, lovely. So we had a second assessor coming in doing midfoot width measurements. They were blind to all the baseline measurements that were taken. That person came in and they then measured the midfoot width, took that measurement and then subgrouped them into high or low mobility. Once they were then subgrouped, they were then randomly allocated to the treatment groups, the treatments that they received. So we had 49 with high that were subgrouped, randomized to treatment, and 169 that were low, also randomized to treatments. We did a midpoint follow-up at 6 weeks, and we did a final follow-up was at 12 weeks post-intervention, 12 weeks from when they started the study. Now, the outcome assessor was blind to both the treatment that they had received and to the subgrouping that they had been put in. We ended up only losing 11% of our population, which is pretty good given that we had counted that we thought we'd have about 15% lost to follow-up. But here was a really lovely thing and the importance of why we did supervise the exercises. We had a really high adherence to our treatments. Most people attended 92% of their foot orthoses sessions and wore the orthoses or the flip-flop thong jandal for 74% of the waking hours. But with regards to the hip exercises, they attended 84% of their sessions. And that's really lovely because we know that we got really strong adherence to this. So here we go, the results. The bit you've all been waiting for and I've taken some time to get to, but it's good to explain the rationale behind it. What you're looking at here is the pure head-to-head of the 2 treatments. If someone presents with patellofemoral pain, where do I start? What is the best treatment to start someone off? Is there a start with foot orthoses or hip exercises, and which one is the best? Remember, we define success as those that reported better or much better. Here we go. There was no difference in outcome between either treatment. Okay. The lovely thing about this is that our foot orthoses results were comparable to what Collins had also reported as well. So we know that our findings are really strong and that's been shown within previous literature. If we look at the hip exercises, and we used one of the largest randomized control trials done that looked at that, it was 199 people. Once we adjusted, because they used different outcome measures, once we adjusted ours, so they used different primary outcome measure or definition of success. So when we adjusted ours to match theirs, we actually found that our results were extremely comparable to theirs as well. So what that means is that foot orthoses and hip exercises seem to offer benefits equally. There's no one is superior than the other. And this was in a group of a group of 99 versus a group of 98. So big numbers that we're looking at here. The second aim of the study was to look at this midfoot width mobility. And again, just to refresh you, more than 11 millimeters, 11 meters or more, we defined as mobile. Less than 11 millimeters, we would define as stiff or sort of low mobility. Our primary outcome measure was the same, was looking at success was better or much better. So here we are. If we look at the foot orthoses group, we've got the mobile and the stiff. What happened? We found the opposite, was that those with the stiff foot actually had a higher success rate with foot orthoses. That this cutoff or this dichotomy of 11 millimeters or more means that you'll have a greater success with foot orthoses. It didn't hold, unfortunately. If we look at the same with the hip exercises, the sort of midfoot width mobility, you may think that a stiff or a low mobility foot, look, you shouldn't need foot orthoses, you're going to need hip exercises. Again, we actually saw something similar here, was that midfoot width mobility wasn't really associated with success with hip exercises. So sort of across the board, this dichotomy, this cutoff of 11 millimeters doesn't really indicate if you're going to respond to foot orthoses or hip exercises. There's no real thing around that would guide you around either way. But here's the thing, we had this dichotomy, this black and white, 11 millimeters more success, less, no, it doesn't. Well, maybe we got that slightly wrong. Maybe the measurement slightly less than that may have a higher success rate. So what we looked at here was sort of, the relationship between, those that reported a successful outcome, or, where they rated across the global rating of change, and their midfoot width mobility. And if this was true, if it was strong, we should see a nice sort of linear line and an R-squared value of 1. What we found was almost a horizontal line and an R-squared value that was extremely small, which shows that there was no relationship anywhere. It doesn't matter what your midfoot width mobility was, it didn't really match well whether you reported a successful outcome with foot orthoses. And this was also true again with hip exercises and true again across the entire cohort. But let's look at our secondary outcomes. We had 20-something of them, 26 if I recall properly, different secondary outcome measures. And what we found within the KOOS, or the knee injury osteoarthritis outcome, which has 5 subscales, was that we found a p-value that was associated with 3 of the 5. But here's the thing is, this favored hip exercises over foot orthoses in the pure head-to-head relationship. But here's the thing, just because it was p-value was less than 0.05, and it doesn't mean it's actually clinically relevant. And it's questionable whether these scores and what we found actually has any carryover and is clinically relevant. You could think about what we say the minimal clinical differences, or how much of a change of score before that comes clinically relevant. And these were kind of borderline to suggest, look, yes, they were shown, but maybe they're not really actually clinically relevant or strong enough that you should carry them through. Across 22 different outcome measurements, we found no evidence of difference between the groups on the pure head-to-head or with the foot mobility. And that was the same with all the patient-reported scores, the acceptable, the treatment success. That was the same across the rest of the questionnaires. There was no difference between the 2 treatments. And that was also true with the performance tests. When we looked at hip strength, pain-free measurement, pain-free functional tasks, and also other characteristics around the foot, there was no difference or no association between them. But some of you may be questioning this. Well, look, your hip exercise program wasn't actually long enough. You should have done more of it to, to look for a better effect. If you'd done more, you may have actually found something. So we went back and actually looked, and I've brought this paper up already as the Ferber paper. It was 199 people randomized controlled trial, and they allocated them to either hip and core exercises versus knee-focused exercises in the treatment of patellofemoral pain. Now, within the hip group, 80% reported a successful outcome to 6 weeks of hip and core exercises. Now, there was a mixture of supervised and home exercises, and they had to do them at least 6 times a week in that study. But here's the thing, their success was defined by a decrease of 2 or more on a visual analog scale, and a change of 2 or more. So someone that moved from, say, a 7 to a 4 out of 10 pain, that was a success, okay? Or if you use the anterior knee pain scale or the Kujala scale, if they had an increase in 8 points across that questionnaire. So there was the 2 definitions of success, either a change in pain or a change in score or both, Okay, and that was how they defined success. But here's the thing, with that 6-week protocol, doing them 6 days a week and supervised and home exercises, and quite a body of strength work that they had to do, they noted an 8% increase in hip external rotation strength and an 11% increase in hip abductor strength. So if we compare the FOHX trial to that, and we adjust our success rates to the same to match theirs, because we took the same questions and we adjust ours to match to theirs and define success in the same manner, we actually had a 71% success rate based on that same thing. This is the hip group, 71% success with 4 weeks of exercises done 3 times a week. We also noted an increase in strength, okay? That the hip external rotation increased by 11% from baseline, and there was an increase of 6% in the hip abductor strength. But here was the interesting thing. As I've mentioned before, we took measurements at sort of a midpoint of 6 weeks. So they did their 4 weeks of exercises, and we saw them 2 weeks later at the 6-week time point, like a midpoint assessment, and then saw them again at 12 weeks. What we noted was that the strength gains were maintained across the 12 weeks. Now, this occurred despite them ceasing the exercises at 4 weeks, and we gave no guidance for them to continue on with doing the exercises. So it seemed to be the strength gains that they seem to have got within 4 weeks, and we saw at 6 weeks, carried across to 12 weeks, despite not doing the exercises. So here we are. What was the clinical kind of implications of this entire study, the entire webinar, and things that I'm hoping that you're getting from this session, and will hopefully spurn a lot of good questions that come from today. Hip exercises and foot orthoses offer equal benefits across a wide range of scores, patient-reported, questionnaires, and physical tasks as well, functional tasks. That this idea that we can individually tailor treatment based on midfoot width didn't hold true, and that midfoot width is not a valid standalone patient characteristic to select midfoot for orthoses hip exercises. So this is where we're at. Well, kind of, well, hang on, that still doesn't answer my question. It's like, well, hip exercises and foot orthoses offer equal benefits. So this is where we suggest, well, actually discuss that with your patient, offer it to them, talk about this stuff, maybe see what they prefer. Well, you can say, well, look, the evidence shows that both of these are good. What do you think? So talk it through with them, but also they do come with a resource requirement and a time commitment. Can they engage and do the exercises 3 times a week and work really hard with these exercises? Perhaps if they're a bit more limited, perhaps foot orthosis is the way to go, knowing that both of them in the early management of patellofemoral pain offer sort of a similar success rate or similar benefits. Thank you. I hope it's been really enlightening for you. I hope it's been able to connect a few dots. I hope that there's been light bulbs where you had some light bulbs, something else has switched on, or maybe shed a bit of light on some biases that you've had in the past as well. I hope that through all of this work that we've done, you've been able to connect a few more dots, maybe link a few things, and oh, I have an idea now about how I can manage patellofemoral pain. And my next person that comes through, I can start to use some of these through. I have to fully acknowledge, yes, I've got the ability to present this to you today, but this has been a huge team effort to get the cogs of this trial done and to go through. And it's really important that I acknowledge all of these people, and there's many more that have contributed towards this whole process to get this study done. Without them, these things wouldn't be possible to do, as well as the financial support that we've received along the way. Extremely grateful for things that have been done. I'm very thankful for all the participants who engaged in the study and fully appreciate everything that they did, as well as the treating physiotherapists that we had in Brisbane and in Aalborg who gave up their time to help us run this study. So the question to us all, where to now? What's the next thing we do within management of patellofemoral pain, the sort of evolution of knowledge? Look, there's so many more dots that can be connected within patellofemoral pain, so many more things to think about, to sort of connect within the body, but also things sort of outside of the body and external factors that may influence upon them. So there's a lot of dots to try and link up, and we're nowhere there fully complete, but we're building on it. We're evolving and we're learning more as we go. These are my contact details. If I've brought up any ideas or research or literature or references that you may have seen and you'd like them, these are my contact. This is my Twitter handle and also my Ulster University email address. If you've got anything that you would like or things that that you've seen today you want to discuss, please do feel free to reach out and we'll go from there. Lovely. So I guess at this point, it's question time. We've reached that point there.
Thank you very much, Mark, for that presentation, quite in detail. So and there have been some questions coming through, some really nice ones, as is the case with these webinars. So I think everyone can see what the questions are. The one that's been upvoted most is, do you think combining both hip strengthening exercise and foot orthoses may enhance your results? And there's, and then the other question is, has anyone looked at combining hip exercise and foot orthoses? So do you think combining them is beneficial, and has anyone done it?
It's a valid question. It's a valid point to ask. It's like, look, let's just, scattergun approach. Let's just chuck everything at them, and let's look to see what happens. It's actually been done before to a relatively good degree with the Collins paper in the 2008 one I've mentioned. So that was 4 different treatment. 4 different treatments. Was foot orthoses, was a 3 mil, just a piece of foam that was put through. It was a McConnell approach, which involves knee exercises and some things as well. And then the 4th one was actually both. It was combined foot orthoses and hip exercises. And this is work obviously done by Bill, and I can see Bill's smiling away here. But and it showed that there was a slightly, that it did have a slightly greater benefit, but I don't think it was significantly different to the outcome of just foot orthoses or the exercises. So, it is a good point. Look, just try both with them. But I think coming back to the point and saying, well, actually, look, what does the patient want? What can they do? What can they engage with? From a clinical point of view, yes, we could try both. Whether it's going to give us 100% success rate, I don't think so, is my honest opinion. I think it may give us slightly higher success, but still, I don't think it's going to give us much more than what we have seen from there.
If I could chime in, Natalie Collins did a systematic review which showed that on a pain score, adding the McConnell program with orthoses at 6 months from memory got an SMD, a standardized mean difference, around 0.8, whereas just McConnell versus placebo was more around about 0.4. So something that's escaped, mainly because it's only in one study, the consensus statements, is that adding the orthosis to McConnell might give you a better long-term result. But it's the McConnell one which is the key thing, not the orthoses, because at 6 months the orthoses by themselves is not as good. So it's just a little nuance in that. It's only one study, and not as strong as all the other studies put together. But in essence, it hasn't really been done well yet. Good answer for that. We have a comment from Ashley, who says, no on average symptom onset was 54 months. Was there any different in results of participants with earlier onset symptoms? So what can you recall from your data?
I actually can't recall that, to be absolutely honest. I don't think that we actually looked at that, or sort of, breaking it up to look at the relationship between duration of symptoms. I know that on average was 54, and that seemed to be quite a consistent thing. And we had an older population. By that, I mean they were 27. And we know that this is a condition that comes on earlier in life. People in adolescence kind of report these symptoms, and it's not until further on down their life it starts to really start to impact them a lot more, perhaps a bit sooner. But I actually cannot recall the results, or if we actually looked at that. Bill, are you aware if we looked at that?
I was hoping you would know. I think because duration is a prognostic indicator, I'm quite confident that the statistician included them as a covariate, and there was no impact of that on it. But as you mentioned, these are older people, and on the whole, there's not many with low durations, so it may not have been a valuable assessment. But between the groups, onset of symptoms didn't make a difference, is my recollection. But the paper would have that, I think, although some of these papers, you have to cut a lot of that stuff out.
I think you're right. I think we did look at duration, and that there was no association between length of duration and successful outcomes, but just not entirely sure on that one. I'll have to check that.
Okay, now Ben Smith's got a few good questions, and as expected,
hey Ben, how you going, buddy?
He'd have some probing ones. So this one here is a good one. No, with no wait and see group, could it be hip exercise and foot orthosis are equally ineffective? So they're no different, but are they equally ineffective?
Okay. And that's a good question. And one of the things that we talked about when we designed this study is like, look, should we have a control group? Like we've got foot orthosis, hip exercises, but should we have a control group, just a pure wait and see what happens in subgroup there? And as soon as we added that thought to the sample size calculation, it blew it out of the water. You know, it actually just made it far too unfeasible to run the study. But I think the crucial thing is actually a lot of the studies been shown before that these treatments on their own, you know, foot orthoses versus wait and see, which was Cap Mills 2012 paper, showed that there was a much higher success rate with foot orthoses versus just a pure wait and see approach. And we know that this is a condition that just doesn't get better with just pure wait and see. There's so much evidence to show that this sticks around. It doesn't get better with rest. So you could say, look, without a control group, we can't say that, and that would be actually accurate. But I think based on the evidence from previous studies and previous things shown is that when you compare this to a wait and see, you know, foot orthoses or hip exercise wait and see, both of them are much more effective. And the wait and see just still have these sort of persistent symptoms that travel through. So yes, we could have added it to it, but then the study becomes more unfeasible. It's just not realistic, or it's too big to do. But that is a valid reason, it's a valid point. But I feel very confident based on previous literature, previous evidence, and what we know about patellofemoral pain, that a wait and see option, you know, these exercises are far more superior than just pure wait and see.
Cool, thanks for that. Yeah, so many of our conditions that we look at musculoskeletal do wax and wane, and sometimes you wonder if doing nothing and just looking at them, the treatments do any better. So good question, Ben.
Sorry,
and
I don't know that one.
Is that me or someone else? Anyway,
I think that someone's Alexa kicking in, and I should record that and use that for one of the answers to my questions.
okay.
Gotta love Alexa, because even Alexa.
Sorry, everyone. That's my wife's Alexa over in the corner. So I've just disconnected her, and hopefully it doesn't come back to bite me. I'm very sorry about that.
Alexa doesn't know all the answers either, so I'm happy about that.
No, okay. Moving right along then, and Ben's, like I said, Ben's got a few ones, and this has been uploaded just recently. So how many people didn't, how come so many people didn't meet the inclusion criteria? What were the main reasons? So you had something like about 2,000 come down to 200, so you could end up with 10%. So 90% didn't make the study. Can you recall, I know it's in the flow chart in the paper, can you recall what some of the reasons for exclusion were? Because this is a valid question when you're coming to implementing these findings.
It is a valid question, and this is the reason I put this into the flowchart, because these were, well, actually that doesn't help, did not meet inclusion criteria. I actually thought I listed it. The key ones, one of the biggest ones was actually they had concomitant injuries. There was some sort of other underlying thing. And one of the most common ones that we saw was, you know, they presented with patellar tendon type pain or patellar tendon issues, you know, that they sort of got pain on doing knee extension activities and sort of more hyperextension, so suggesting that there was a real degree of fat pad sort of irritation was the problem. Now some may say, well, look, actually fat pad is patellofemoral pain, but these people got, you know, pain under different sort of presentations or different activities that made their knee. And the other one was actually that they had done hip exercises before. But one of the most common ones was actually they'd had knee injuries, you know, some sort of meniscal injury or some sort of tear. There was some sort of degree of laxity in and around the knee. And I remember that being one of the most common things. You could just pick up this laxity, or they reported having some sort of tear in an MRI that was done on them.
And I guess the other thing to remind everyone is that we recruited from the general population through social media and advertisements. So, you know, there's a fair percentage of these people that just aren't, like you said, aren't patellofemoral pain. So rather than going through clinics where people turn up with pain.
Often when you advertise for a treatment, you know, be involved for treatment for knee pain, you get a lot of people writing in with all sorts of histories. So, and they're captured within those that were excluded. Yeah.
Another good question that came in really early first and it's been upvoted is by Ron. Why doing calf stretches? Any indication? Generic for all patients? Gastroc encephalitis? Query.
Yeah, so that was part of the Collins 2008 paper. That their protocol that we followed through was doing a degree of calf stretching, and that was it's in the protocol paper, the pictures and the exercises they had to do. But it was you know, straight knee against the wall, so sort of a standard gastroc or triceps surae type stretch. Thought being is that, look, if you've got this degree of greater mobility, that the calf muscles are having to work harder, they sort of develop some sort of tension in and around the calf. So like you're trying to relax the muscles off, you're trying to sort of get greater, you know, or sort of release the tension, so to speak, in the calf. Foot orthoses helping that one as well. So it was a straight knee triceps surae or gastroc stretch, if you want to call it that. And the thought was that, well, that was what came through from Collins, but also thought to help kind of relieve some of the calf tension that people often report with this condition.
Yep. And yeah, tight calves and lack of tailcrural dorsiflexion is one of the things that makes orthotics very uncomfortable. So that's why we did it in the Collins paper study from memory. Thanks for these questions. They're coming in thick and fast. Do you think that increasing intensity of the exercise could have made a difference, or different exercise in weight-bearing positions?
That's a really good question, and it's one that I often get. Well, look, where do you start? What's the first exercise that you give somebody? People may say things like doing, you know, the crab, not the crab, clams, or lying on the bed. It's too easy. It's not hard enough. It's not intense enough. It's not loading the muscle up enough. But often we find is that people have, you know, for want of a better description, a real reduced capacity, or a lack of awareness around these muscles, you know, and what they're kind of doing within the hip. So you could look to say, look, should I be doing more functional training, or should I start off with the very basics first and then progress them through from there? So we went with the approach of actually starting with the basics first, starting to get some awareness, some movement, coordination, some awareness on how to use the sort of posterolateral muscles, and then start to progress them through. And our target was like, where do you start with somebody? And let's start with the real basics with a simple 4-week protocol that, yes, in clinic, you would then progress, you would build, and you'd move up from there. But what we went with was just a simple, this is where you're going to start with a really nice, simple, basic one, and then you could progress through there. Whether we may have seen different outcomes if we increased the intensity or if we'd chosen different exercises, you know, my gut feeling, personal belief, you know, just to put that hat on, I don't think we would have seen much of a change in the first 4 weeks. Yes, there are different exercises you can use, but if the person can't perform them well, if they load up the pain, if they keep their symptoms persistent, it can actually become more of a detriment. Hence, that's why we stripped it right back to nice, simple, basic stuff. Start there, and then you can build on from that sort of thing. So I don't think intensity would have changed our outcome, and that's why we chose those specific exercises from there.
Cool. Now some of our students are starting to ask questions, which is good. Apart from Zach asks, apart from foot width, do you think there are any other characteristics that could be explored into the future which may indicate orthosis over hip strengthening?
Okay, yep. So let's just shoot back to this one. This will just help support the talk a bit more.
Make your slides.
So there was this. Was that, sorry?
Yeah, just make your, good, yep.
Yep, you can see it. Lovely. So this was looked at the systematic review that we looked back and looked at treatment effect modifiers. And as I said, there was 6 treatments across 12 studies. 6 studies looked at foot orthoses. 14 of those were associated with a successful outcome with foot orthoses. And things that were reported were such as navicular drop, which is the change in height of the navicular, to see how much that drops through. So I guess that's some degree of movement of just a single bone or a single sort of point on a bone. Other things like ankle dorsiflexion, range of motion was also something else that was suggested as well. So look, we looked at one, but that movement itself, the midfoot width mobility, captures a lot of what's happening through the entire foot. Navicular drop is focused just purely on one bone. Midfoot width is kind of trying its best to capture movement across one plane. But it is important to acknowledge it is, you know, foot mobility is a 3-dimensional movement, and it's really hard to get a simple clinical measure that can measure all of that. So we did look at navicular drop, we looked at foot posture index, we looked at ankle dorsiflexion, you know, we looked at midfoot width, we also captured arch height as well, so change in arch height or difference in arch height, and none of those were associated either. Right, so our primary focus in subgrouping was midfoot width, but we did capture other foot characteristics. and they weren't associated with a successful outcome as a standalone measure. But one thing I think is worth, and perhaps that's where we can move forward with the future, is look, there is definitely a subgroup of people who do respond well to foot orthoses. You know, that's true. We just haven't yet worked out how to best identify them. And maybe it's actually a cluster of clinical measurements that we can use. Maybe that may have an associated outcome with success. And that's one of the things we may go back and look through all of the data that we collected and start to look at perhaps a cluster of 2 or 3, maybe 4 different measurements to see how they actually respond. And there's this sort of cluster suggestive that, look, if you've got these factors, then you're more likely to have an outcome rather than just a simple standalone measure. Good question, and definitely something worth, you know, that we need to keep pursuing further.
Thanks, Mark.
Good one, Zach.
James,
You're gonna get top marks in your class now.
James has asked the question, in those who are prescribed foot orthoses, if the treatment is successful, in other words, you know, they feel a lot better, totally better, would you suggest to wean off the orthoses or continue to wear them?
That's an interesting effect because you're thinking of along those lines of actually the mechanism effect of a foot orthoses. You know, if you've got a foot orthoses, that you've got something that foot orthoses is contributing to something, you should wean off them. Look, we actually, you know, there's no evidence to say how actually foot orthoses do work, the mechanism effect. There's a lot of different mechanisms and everything really is focused on comfort. You know, and the evidence has been shown that, look, foot orthoses can have an impact in the short term for pain and modify pain from there. It's an interesting question. Should you wean them off them? Bill and I published a chapter in a book around for clinical reasoning around midfoot width mobility as sort of an indicator, as a case study. And it was a lady that we saw and treated, and actually she far preferred the foot exercises, you know, and we modified and progressed foot exercises for her and took the orthoses away. Now that was based on, she kind of didn't like them, they weren't comfortable, but by doing something around the foot, the exercises, some sort of active intervention, she actually had a good successful outcome with that. So evidence suggests foot orthoses are good in the short term and that you then progress on from there. My answer is to give you more direct answer. I think it comes down to patient preference. If the person feels that they're helpful, then just keep working with it. But I'd always be looking to sort of build on top of it and keep progressing through. We know they foot orthoses work for the short term, but it's good to keep progressing things along, whether it's exercises around the foot, around the knee, or around the hip, to keep working forward from there.
Cool, thanks, Mark. We're about an hour into the webinar from where it actually started. There are some questions on the list that I think could be directed at the panel. There's a few that have been upvoted that I think are particularly for Mark, so we'll continue with these for a little while, but we'll get to the panel shortly, rest assured everyone. So Tim asked, did the participants in the study actually have deficits in hip abduction strength? On the symptomatic side? Was this measured bilaterally prior to exercise commencement? This would certainly alter the treatment effect.
Okay, so the suggestion there is that, and with the rationale is that, look, if someone's not strong enough or there's a deficit or some sort of motor impairment or movement issue, and that if you strengthen it, if you address that deficit, and the systematic review done by Michael showed that actually the deficit may be as a result of patellofemoral pain more than sort of cause patellofemoral pain. The question is, or the answer is actually, we don't know what is a true deficit. We don't yet know if someone is strong enough at the hips. You know, what is strong enough? So to identify that they're a deficit or that they're a bit weaker is also relative to the context of what they're doing. So it's hard to know exactly if they're a deficit, but one of the things I'm really interested in is sort of more around symmetry index. You know, left versus right, or abductors versus adductor groups. If there's some sort of disparity or something different within a limb symmetry index, if they've got less than, say, and that's been shown with other muscle groups, you know, with hamstring injuries, for example, you know, if there's a greater difference of more or a difference of 15% between the two of them, there may be something around that that can identify deficit. Now, if we can identify that, then we can start to identify those that are presenting with a deficit, then we can see if hip exercises are the best one for them. And that yet hasn't been explored. You know, what actually is a deficit with the hip muscle that would say, look, you need strengthening exercises. Historically, we may do, you know, lying on the bed, hold the leg up, hold it for as long as you can, you know, and you feel the burn or fatigue, or, you know, we hold the leg up and as physios, we love to wrench on it and give it a push, you know, and see if they can push against you. Crude, hence that's why we use the handheld dynamometers. We did that in supine lying with external belts resistance to hold them in place. Have a look at the protocol paper. You'll see how we recorded and measured hip strength. And then we want to sort of, that's one of the things we may look at with our studies, is going to look, is there something around the symmetry index that may identify those that would respond best to hip exercises? So definitely that's another dot of where we need to keep moving and keep evolving our research further. Those that are weak, so to speak.
One thing that we have done and we haven't published yet is the statisticians done a moderation and mediation analysis of this data. It doesn't seem that those that were weaker, it doesn't seem hip abduction strength is a moderator. In other words, those that are weaker benefit more or less. But it makes clinical sense that if someone's weak, you'd strengthen them. But this study didn't actually show that. And there's, just under 100 people in this group, so it's not like a small study where you're likely to have missed something.
There's something else you've just reminded me of. We looked at hip strength in all groups. So there was those that got the hip exercises, and we looked at their hip strength, at baseline 6 and 12 weeks. And as I've shown you there, we had an increase in strength. With the hip exercises, 11% with external rotation, and I think 6% with abductors in response to a 4-week program. There was also the other group that got foot orthoses, so a distally targeted treatment. We also took their hip strength values. And at 12 weeks, there was no difference in the hip strength gains. What that suggested was that something targeted at the foot has done something to modify what's happening more proximally up at the hip. The foot orthoses group also got stronger up in the hip muscles, and there was no significant difference between the two at 12 weeks, suggesting that maybe the mechanism of effect of the treatment is actually through the entire kinetic chain. It could also be symptom modification. We changed their pain, they became more active, and therefore they also became stronger as well. So it's something that you would think, if I target the hip with hip exercises, I'll make the hip muscle stronger. But also, what is shown with the study is that also the foot orthoses changed hip strength as well. So an indirect effect. How? Not sure. It could have been a few things. Sorry, Bill.
No, you're right, mate. There are some questions coming in about, where would you start and et cetera clinically. We might leave that kind of question when we get to the panel, like clinically, what do the panelists feel, is the go-to for them and why, so that we can get an overall start to that. So I'll leave that, the top question here, where does Mark now start with his patients to then, and you could probably kick that off then, Mark. There's another question, why did you exclude 90% of the 2000? I think this has already been answered. Does your group properly reflect the population that presents to physio clinics? So the big thing that I'd like to say here, because I've had this discussion this week, is that in Australian healthcare context, we cannot get any patients through physio clinics. It just doesn't happen. So we just go with people that, just to give you a bit of a break, Mark, this is
I appreciate it.
This is a technical thing, essentially. So do the research, we go broader. We do tend to have caveats, like we ask for certain severity, a certain duration of pain that might reflect clinical practice. But when you look at it, our effect sizes for orthoses and hip exercise are much like others that have published. And so the effects seem to be robust across populations. Whether they represent who turns up to physio clinics is not that easy to answer from our data. So I might just leave it at that. It's always an issue of that external validity. It's a good question. Yep. There's a question here. Callum asked, he was wondering what were the specific models of prefab insole sandal type shoes that were used. Do you want to answer that one? That's a rather straightforward one, I think.
Yep. Let's bring the picture up. So these were the orthoses that we used. They're prefabricated, off the shelf. They're made with EVA foam. You can see the big long one. That was what we would call a full length. So that goes right into the toe box of the shoe. And goes through, there's a heel cup with the sort of supports through there. The second one the shorter one, this one through here, is what we call a 3/4 length. And that's for someone who may have a shoe design that actually doesn't allow that foot orthosis and it's too tight at the toes. So you're still looking to try and have that sort of effect around the rear and midfoot region, but the shoe itself doesn't sort of give them the chance to, or it's too tight around the toes. The third option, the wee small one that you can see at the back, that's what we call an easy fit. And you can see that that portion to the outside of the shoe has been cut away. And that's to fit in sort of more type, business shoes that have a real restriction of space, where things are quite tight to begin with. You still need to fit something in through there. So the physios had this whole range of orthoses that they could use with each individual person. They brought in 5 to 6 different pairs of shoes, and they were fitted with all these different models to their kind of most common shoes. So the answer is that, look, we had a wide range that you could use. They could be modified. You could put wee wedges up here around the toe. You could put heel wedges that also came fitted in. As I say, it was entirely based on making it comfortable. And that was the standard contoured sandal, thong, jandal that we used. So that was also an option that was given to them as well. So they had a lot of different things that could be fitted to the shoes based on the shoe, based on comfort. Okay. And that was the same as what the Collins paper had done as well.
So essentially this study used what's been done before and now has been studied the most, but we haven't studied different models of different companies' models of orthoses. Yep. The custom orthoses have not been studied in great detail in patellofemoral pain, but in other conditions, there doesn't seem to be much benefit from the custom. There's a new study coming out that shows it's no better than just usual care to have customized orthoses. One of the problems, of course, with all these orthoses is there's so many different characteristics that different people think are important. Most of them are not evidence-based, unfortunately, but which leaves it difficult for clinicians to know what to go with. So we made it pretty clear. It's comfortable orthoses that are fitted to a patient that looks like they've got an increased mobility, even though this study doesn't bear that up for the measures that we measured. I'm looking at these questions and I think I might, do you want to unshare your screen, Mark, and I'll ask the panelists to.
Geez, the questions are flying in. Good.
There's quite a few here.
Yeah, good.
I don't want to.
Here we go. Is that, I stopped sharing.